Hello and welcome everyone. I want to start out by letting everyone know that today's session will be recorded. You can avoid being recorded by keeping your microphone on mute and not typing in the chat. By unmuting your microphone or participating in the chat, you are consenting to being recorded. So again, hello and welcome to the presentation, Diagnosis and Treatment of Tourette's Syndrome and Tic Disorders. My name is Lindsay Goss and I am a faculty lead and lead nurse planner at Southern New Hampshire University. SNHU is accredited as a provider of continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. This educational activity does not include any content that relates to products and/or services of a commercial interest that would create a conflict of interest, and no commercial support has been received for this event. First, a few housekeeping items. During the presentation, the chat box and microphones and cameras will not be available. There will be about 10 to 15 minutes at the end of the presentation for questions and answers with our presenter. Once the Q&A portion of the presentation begins, the Q&A can be used for questions. At the conclusion of this webinar, you can access an evaluation link within the continuing education platform. In order to receive contact hours for attending this presentation, you must complete the evaluation by November 11th. Now I'd like to turn the presentation over to Angela Sullivan, who is the Manager of Programs and CDC Cooperative Agreement Project Director. Welcome, Angela, and thank you for being here today.
Hi, everyone. Thanks so much for being here, and we are also happy to be here. Before I pass it over to Dr. Morrison, I want to just take 2 minutes really quickly and introduce a little bit about the Tourette Association and the program you're all here for today. So as Lindsay mentioned, my name is Angela Sullivan. I'm the Manager of Programs and the CDC Cooperative Agreement Project Director. It's a mouthful. And I wanted to just share a little bit about the TAA. So we are a national nonprofit organization. We're located in New York City. And we are the only national nonprofit that is out here serving and providing resources to those affected by Tourette syndrome and tic disorders. Today's program is being sponsored by our cooperative agreement with the CDC. We actually just entered our 18th year of partnership with them as of September 1st, and with their support have been able to travel across the country, both virtually and in person, to give presentations like the one you'll hear today. We give workshops on CBIT, which is a behavior therapy used to treat children with tics. You'll hear about that a little bit today. And we also give presentations in schools to educators on managing Tourette syndrome in the classroom. Next slide, please. So at the TAA, we are dedicating to making life better for all people affected by Tourette syndrome and tic disorders through efforts that raise awareness, advance research and understanding, and provide support. Next slide. So awareness, research, and support are the 3 main pillars of our organization, and these are the ways that we provide our community with the resources that they need. We do lobbying on Capitol Hill for continued funding of our programs and resources. We provide Young Investigator Awards and money for grants and for young investigators to develop new treatment options for Tourette syndrome. And through our support network of chapters and support groups that are located across the country, we're able to provide the community on the local level the information and resources that they need. We also do have centers of excellence, which are big or small hospitals that are doing the best work in treating and managing patients with Tourette syndrome, and Dr. Morrison is actually located at one of them. Next slide. And last, real quickly, I wanted to share that with the CDC's support, we've also been able to develop a very comprehensive library of resources for providers like yourselves and patients. All of this information, all of these guides are free to download on our website. And I do believe I sent some out to Lindsay at SNHU. I know some of you may be remote, but if you'd like in-print resources, happy to mail those out to you as well for you to share amongst the community. And the last thing I wanted to mention too, I know that you have to complete an evaluation for receiving credit. At the end of the presentation, there will be a slide with a QR code. And this is a quick survey just to provide your feedback about the presentation itself for us to report back to the CDC. As we said, they provide a lot of great funding for us to do a lot of educational programs across the country, and with your feedback and support of this, completing this really quick evaluation, we can continue to receive funding from them. So that's it for me. I'm going to pass it off to Dr. Morrison. Thank you all again for being here. If you have questions, leave them in the chat for us. Thank you. Oh, I forgot, we have polls. So really fast, I think, Mike, if you want to launch the polls for us, we just want to get a sense of the audience and kind of what your experience is, if any, with Tourette syndrome disorder. So it's launched there for you now for Dr. Morrison to get an idea. Thank you.
All right, I'm not sure if that was long enough for the poll question, but I'll go ahead and get started. So again, my name is Pete Morrison. I'm a movement disorder neurologist at the University of Rochester Medical Center in Rochester, New York. I really enjoy giving this talk, so I'm really honored to be here today. And not only do I see and treat patients with tic disorders, but this is near and dear to my heart in that I was diagnosed with Tourette syndrome when I was younger. So not only do I have the patient perspective, growing up, being treated with Tourette syndrome, but now I'm on the other side. It's been a very rewarding process for me in terms of understanding patient aspect of care and the clinician aspect of care. And so I'm really happy to share the program with you today. And overall, if I can get this going, there we go. What are we going to learn today? So, the scope of this talk is going to encompass a lot of different topics, and some of the topics may be relevant for you, some of it may not be as much, but everyone is going to be able to get something out of this presentation today. But overall, we are going to look at the criteria that are used to diagnose Tourette syndrome and other tic disorders. We also want to understand what are the potential health disparities in individuals with Tourette syndrome and other chronic tic disorders. And to be honest, the data is very limited, and we need to do a better job of that. We also want to look at ways to optimize the educator-provider relationship. This is very important because, our educators do a great job supporting our students and individuals with Tourette syndrome in the school. But providers, we can also help in terms of providing letters of diagnosis, ways to support co-occurring conditions. There is a way that we, as providers, can help our patients in the schools. We're going to look at outlining the range of effective management and treatment strategies for patients with tics. And that's just not with medications. That's with non-medication approaches, which you'll be learning a little bit about today in CBIT, or Comprehensive Behavioral Intervention for Tics. And last, we want to look at the common co-occurring conditions that are seen in patients with Tourette syndrome and tic disorder. Because in the end, a lot of times, as you'll see, the tics improve with age, but it's the comorbidities, whether anxiety, depression, OCD, ADHD, that tend to linger on into adulthood and become more problematic. So the first thing to do is we have to define what a tic is, okay? Tics are not insects, they're not tic-tacs, they're not contagious, and they're absolutely not a sign of mental instability. As a movement disorder neurologist, when we define movements, that's called phenomenology. So we have to describe the phenomenology of tics. These are repetitive, stereotyped, non-rhythmic movements or sounds. And a lot of times, patients endorse what's called a premonitory urge or a buildup or sensation that they're going to happen. Tics are involuntary, they're out of the control of the individual, but they do have this component of temporary suppressibility where if I think about it, I'm not going to do it, I'm not going to do it, but eventually that urge builds up or they get distracted and the movement or sound happens. And a lot of time there's this relief after the movement or sound occurs, and sometimes what we call a just rightism, like I just got the right pressure in terms of having the tic. So again, it's important to understand because not all movements are tics. And in movement disorders, there can be tremor, ataxia, chorea, myoclonus, and each individual movement has a definition, and that's the point of this, is that you really got to make sure that you are dealing with tics and not another movement disorder. So what kind of tics do we have? Well, a lot of times what you're going to see are the motor tics. A lot of times they involve the cranial cervical distribution in terms of simple tics, eye blinking, eye squinting, nose wrinkling, neck twisting, mouth grimacing, but then there can also be vocal tics, such as clearing the throat, sniffing, grunting, barking. As I mentioned, those are a lot of the simple tics, but then you can get these more complex motor and vocal tics, which are more coordinated movements or sounds that people make. And the ones that we hear about in terms of complex vocal tics is coprolalia, or where people will swear. What I would say is that's very uncommon in terms of patients with Tourette syndrome, usually less than 10%. But you can have both motor and vocal tics. And in theory, it's more semantics because in order to create a vocal sound, you have to have contraction of a muscle. But we basically look at having both motor and vocal tics. So now we have to define what are the different tic disorders, because we know what tics are. They're these repetitive, stereotyped, non-rhythmic movements or sounds. We know that there's both motor and vocal. So the first diagnosis that we look at is something called a provisional tic disorder. This was formerly classified as a transient tic disorder. And essentially what this is the presence of either motor or vocal tics for less than a year. It is not uncommon in children during development to have tics. Depending upon what literature you look at, about 15 to 20% of individuals will have tics at some point in their childhood, but they typically last less than a year and then resolve. With that said, there is a subset of those individuals, about 1%, where tics will last for greater than a year. And that is the threshold, which then leads us to what's called a chronic tic disorder. There are 3 different kinds. Initially may look confusing, but it's actually fairly straightforward. So you have those individuals who have only motor tics for more than a year, but no vocal tics. That's called a chronic motor tic disorder. Then you have those individuals who have only vocal tics, but no motor tics for greater than a year. That's called a chronic vocal tic disorder. And then there's Tourette's syndrome, which is the combination of 2 or more motor tics and at least 1 vocal tic for greater than a year. But in the end, it's technically more semantics than anything. Whether it's just vocal tics or motor tics or both for greater than a year, it's the same underlying pathophysiology, but these are the different terms that you will see in terms of diagnosis coding. So looking at Tourette's syndrome specifically, which is the presence of at least 2 motor tics and 1 vocal tic for greater than a year, this was first described by Dr. Georges Gillet de la Tourette in the late 1800s. And unfortunately, it was initially regarded as a psychological condition. But over time and with research, we've obviously understood that it is a complex neurodevelopmental disorder with both neurologic, psychiatric potential component, as well as maybe a genetic component. You know, we're not quite there yet in regards to that. Certainly there are different neurologic diseases like Huntington's disease, where we know it's the mutation on chromosome 4 with greater than 40 CAG repeats, you're gonna have the disease. We're not there yet with Tourette's syndrome. It's likely a combination of developmental, environmental, and maybe some genetic components. In terms of overall prevalence, again, depending upon what source you look at, it's about 0.5 to 1%. And overall, males are more affected than females in about 4 to 1. So looking at the health disparities in Tourette's syndrome, what do we know? Well, unfortunately, to be honest, it's limited, and we don't know a lot, and we need to know more. From what we do know in several studies is that lower socioeconomic status identified as a risk factor for patients with Tourette's syndrome or chronic tics. We also found that publicly insured TS patients have higher tic severity and higher comorbidity rates than privately insured patients. And last diagnosis is more common among white non-Hispanic children compared to Hispanic or Black non-Hispanic children. But again, that's just the tip of the iceberg. We really need to have better studies to really look at this, to understand the health disparities that are there. And we're still lacking data in terms of time of onset of symptoms to diagnosis. Those are not the same thing. A lot of times patients will have symptoms years before the accurate diagnosis is made. Then understanding the comorbidity rates across different racial, ethnic minorities and socioeconomic backgrounds. Again, these are all very important that we really need to know, that further research can hopefully shed light on. So when we talk about the clinical features of Tourette's syndrome, the onset of symptoms typically has to be less than 18 years old. In average, looking at the studies, onset is around 5, 6, 7, 8 years old. Yes, it's a bell curve and you can have onset in your late teens, things like that. But if someone presents to me at the age of 32 with onset of tics, that is very, very atypical and unusual. And at that point, we have to consider something that's called a functional movement disorder, which is a different diagnosis that we look at. But in general, less than 18 with average age of onset, 5, 6, 7 years old. Tic severity tends to peak 9, 10, 11, 12, 13. And in general improves with age. But that tic severity is very subjective. There was a study done that basically showed this, but when you ask about tic severity, that's different for every individual. Is it one tic that's very large amplitude and bothersome? Is it the number of tics that you have? Is it the frequency of tics? So again, there is some subjective nature regarding tic severity when you talk to individuals with Tourette's syndrome and tic disorders. But in general, we see initial uptick 9, 10, 11, 12, 13, and in the majority of individuals, about 75%, they improve in frequency and severity. It's important to know that tics wax and wane. They ebb, they flow, they come, they go. That could be hour to hour, day to day, week to week. All of our movement disorders, not just Tourette's syndrome, are worse with stress and anxiety, heightened emotions, or anticipation. As I mentioned, tics improve with age in the majority of individuals, but not always. And there is a high association with tic disorders and Tourette's syndrome with ADHD, OCD, anxiety, and depression. And this is one of the major take-home messages that I want people to understand today, is that it's not just looking at someone with tics. It's also screening for these common comorbidities that in general tend to linger on into adulthood and are most impactful day to day. So this was that graph that I was mentioning before. This is an oldie but goodie back from 1998 in the Journal of Pediatrics, where we see the relative tic severity of the patients that were questionnaire peaking 9, 10, 11, 12, 13, and then improving with age. But as I mentioned, there is certainly some subjectivity in terms of how these individuals are discussing their severity of tics. So what is the educator-provider relationship? So us as providers, whether it's physicians, nurse practitioners, physician's assistants, nursing staffs, we certainly can play a role in terms of helping support our individuals and students with Tourette syndrome in the school. We can recommend and encourage outside therapies, occupational therapy, physical therapy, even if it's not necessarily for Tourette, but just to help support our kids. We can write a letter to the school stating what their diagnoses are, what potential accommodations should they have. If there's complex anxiety, ADHD, maybe a full psychological evaluation is needed to kind of look at the severity and breakdown of these different symptoms. Because again, it's not just the tics that patients with Tourette syndrome can struggle with in school. It can be the ADHD, the OCD, there can be executive function deficits, some learning disabilities. So again, from a provider standpoint, obviously we are crunched day to day with what our demands are. But going that extra mile and at times making that phone call to the school, making that phone call to the teacher can really help support the student better than maybe what they would have had in the past. Here are just some additional resources for educators. Again, we can certainly provide all these resources at the conclusion of the meeting, but here are some things that I just wanted to share with everyone. So next, I'm going to play a video of an individual with Tourette syndrome, just to give you a sense again of what the tics are for this individual, how they were diagnosed, and basically how it has affected their life going forward. So I'm going to pull the video over because it plays better when it's not embedded, and here we go.
All right, so you're how old now?
I'm 23 years old.
Okay. And do you remember how old you were when anyone first pointed out to you that you had some unusual movements?
I was about the age of 6 to 7 years old, and I was in about first grade when I was first told about myself.
Okay.
Also, one time that when I was a little bit younger, I had probably about maybe 4 or 5. I was at my one friend's house, and I was having one of my tics, and I was playing a video game, and my legs are going like all over the place, and I was making facial features.
Mm-hmm.
And my mom's friend called her to let her know about it. She thought there was something wrong with me. She thought I was having a seizure or something.
Yeah.
But my mom was like, "Oh no, he's fine. It's just what he does all the time."
Right.
So.
All right. Have you found that medicine has helped you control these?
The medicines helped me keep them underneath control, but that's the key thing is kept under control. It's nothing that's
Right.
completely helped me get rid of it or anything.
But the only time it bothers you is what? When do they actually bother you? Is it...
A lot of the times when they bother me is stress. When I'm kind of zoning out and then like daydreaming and things and sorts, or I guess typically I notice they do come out when I'm not taking my medicine and stuff like that.
But how does it bother you? Does it cause pain or?
Not so much pain, maybe more tension.
Mm-hmm. Where does
the top part, around the shoulders and neck,
mm-hmm.
is where I notice a lot of it. I get some tension in the insides of my hands from when I do different hand stuff and I strain and stuff with my hands. But as far as any other pain, I don't really feel that much pain. I'll get some neck kinks and stuff and sorts, but
if you could do something tomorrow that would cure this completely,
mm-hmm.
would you do it?
Yeah, I guess. I mean, I wouldn't want to take away what I've learned from it, I guess, because it's helped me learn to try to, like, I don't know, I guess be more of like an individual. And because it does kind of make it so where I have to learn twice as harder, I guess it makes me more of like an independent in terms of trying to be a little bit more stronger in learning aspects. So I don't want to take away from that what I learned from it, but at the same time, to be able to get rid of it to help me be able to learn better, you know, not having to be a distraction and be able to, you know, be able to do my homework in an hour instead of having to take 2 hours to try to control my tics and sorts.
Right.
I wouldn't mind it at all if there was a way that I could do something to kind of cure for it.
So I really like to share that video for a couple of reasons. One, it's a good segue when we go into talking about treatment of patients with tics and whether or not we need to even treat, but also to understand and really to educate our patients, you know, because a lot of times this can really come, you know, as not a disappointing diagnosis, but discouraging. And in the end, you know, what I always tell parents and individuals is that, you know, Tourette's syndrome is not going to define you. It's just another aspect of who you are. And it's not any different per se than hypertension or hyperlipidemia or diabetes. And you can see that individuals with Tourette can continue to go on and be successful. And so I really feel a major aspect from a provider standpoint when we're making these diagnoses is to educate the patient and the family and their loved ones. You know, what is Tourette syndrome? What is the outcome going to look like? And how can we best support? Going to the next section, though, in regards to treating, the most important question that you have to ask is whether or not you need to treat. Because in the end, just because someone has tics or tremor or chorea doesn't mean that you need to treat. You only need to treat if the symptoms are impacting quality of life. But again, quality of life, that's a loaded question. So ways that I look at that is what is their impact on activities, school, social interactions, self-esteem, bullying. You know, is there pain and discomfort? Because a lot of times, as I just mentioned, education of the diagnosis and how the tics wax and wane, they ebb and flow, they come and go, they typically get better as you get older, a lot of times is enough. If you are going to treat, the goal is not tic suppression. The goal is not elimination. It is to help improve the frequency and severity, because in the end, there's probably going to be some degree of tics, but you just want to improve the frequency and severity of the tics that improves quality of life. You don't want to treat the parents, okay? So that's another big aspect of this, is that I've had several patients come in and their parents are like, you know, Dr. Morrison, I see Johnny, he's on the soccer field, he's ticking 200 times. It's got to be so bothersome for him. Then I asked Johnny, and I'm like, Johnny, do these tics bother? And he goes, no. So in the end, you really just got to maintain focus on the patient, understand what the impact of these symptoms are on the patient. Yes, it's important to get collateral from the parents, but you want to make sure that you're treating the patient. And again, focus on the most bothersome first, because it could be the tics, but it could also be the comorbidities of anxiety, depression, OCD. So I really like to kind of triage what are the most bothersome symptoms, start with that, and then go from there. So before we get into the actual recommendations, I just want to make people aware that in 2019, the American Academy of Neurology did publish new practice guideline recommendations in terms of treatment of tics in patients with Tourette syndrome and chronic tic disorder. So this could be a very valuable reference, for which it is there at the bottom of the screen. So when we talk about first-line treatments for patients with tics, in my opinion, it absolutely is comprehensive behavioral intervention for tics, or CBIT, which is a non-medication approach for patients with tics. It is a form of habit reversal therapy, but I don't like to consider tics habits because they're not. But basically, what it's utilizing is the premonitory urge, what I mentioned before, this kind of build up this sensation prior to the tics occurring. And what happens is you develop a competing motor response. So let me give you an example. Let's say my bothersome tic is a neck rotation to the left. When I feel that urge or build up, maybe I'll just tuck my chin in my chest, wait till that urge passes, and then release. So you can't do this neck rotation and this chin tuck at the same time. That's why it's called a competing motor response. Then sometimes patients will say, well, you're just trading one tic for the other. And the answer is no, because this movement, the competing motor response, does not satisfy the urge that that neck rotation does. Then the patient may ask, well, what if I have 20 tics? Am I supposed to develop a competing motor response for each one? What I say is no. You focus on the tics that are most bothersome, you treat those, and a lot of times that's enough to improve quality of life. When we talk about, well, who provides this? You know, where do we get access to this? So neuropsychologists, psychologists, and even occupational therapists are being trained in terms of doing this therapy. And the TAA has done a really great job over the years to try to get more and more providers access to this training, because in the end, the rate limiting step to this is access. Interestingly, with the pandemic and the improvement in access of telemedicine, I feel that we've been able to have access to patients that may have necessarily not had access to before. For example, in terms of upstate New York, in the northern part of New York, they drive 3 to 4 hours, and before they would have had to come in person, and that's a 6 to 8 hour round trip once a week for 8 weeks. Now that we have telemedicine and it's being covered, we're able to do that a lot easier. Now it's always fine for me to say that CBIT is the first line therapy, but what is the evidence behind it? We as providers like to have evidence. Well, so we first have this randomized controlled trial of 126 children aged 9 through 17 with either Tourette or chronic tic disorder. Basically, there were 8 sessions of either CBIT or a controlled treatment of just supportive therapy and education. And what they showed was that the behavioral intervention with CBIT led to significantly greater decrease in the Yale Global Tic Severity Scale compared with the control treatment. Now, the Yale Global Tic Severity Scale, or the YGTSS, is the motor outcome that we look in our studies for patients with tics. You always have to have some type of outcome. In Parkinson's, it's a UPDRS. In Huntington's, it's a UHDRS. For tics, it's the YGTSS. And this was statistically significant. In addition, they found that significantly more children receiving the behavioral intervention compared with those in the control group were rated as either very much or much improved on the Clinical Global Impressions Improvement Scale. Dropout rate was fairly low at 9.5%. And in addition, it's important to note that the treatment gains were durable, and that 6 months after the study was completed, they showed that 87% of the responders were still exhibiting good control of their tics with this intervention. So then the next step was to take this with children, because there are still adults who have tics, and see if we can translate this to the adult patients too, and we certainly did. Again, there were 8 sessions of CBIT versus supportive therapy over 10 weeks. Again, the CBIT resulted in significantly greater decrease on the YGTSS compared to the supportive control group. In addition, they showed significantly more adults receiving CBIT were rated as either very much improved or much improved on the Clinical Global Impression Improvement Scale. Dropout rate maybe was a little bit higher, but honestly was not too much different. And again, the treatment gains were durable, reassessing at 6 months later. So overall, here is just kind of a summary of those 2 studies, both in the child and the adult. And this is looking at the Clinical Global Improvement Impression Scale in terms of 52.5% for either very much or much improved, and 38.1% in the adult group. So let's say that you've done CBIT and it wasn't effective, or you don't have access to CBIT. Then pharmacologic intervention with medications is the next step in terms of treatment of tics that are bothersome to the individual. As you see here, there's a list of different groups and categories of medications that we can use. Now, in the end, you may not be prescribing these medications or following them, but it's important to understand their names, their mechanisms, and why our patients are taking them, and what are the potential side effects, because commonly you will see this happening. And again, even if you're not prescribing, it's important to understand that there are these different medications available. As I'm going to go through the alpha-2 agonists of the first line, less commonly we use the Anti-Dopaminergics, sometimes Topamax, and then less commonly the others on the screen. So let's first start with the alpha-2 agonists. So overall, these are considered first line from a medication standpoint. Again, CBIT is the first line regardless, but if you have to go to medications, then the alpha-2 agonists are the way to go. And that's in either clonidine or guanfacine. The mechanism is that it binds to the alpha-2 receptors within the central nervous system, decreasing sympathomimetic outflow. As I mentioned, it's considered first line for treatment of tics. In addition, it can be also effective for ADHD, so you kind of get this 2 for 1. Now, when we talk about ADHD in a little bit, stimulants are just overall the most effective from a statistical standpoint. But if someone has both tics and ADHD and may not want to do stimulant, then the alpha-2 agonist may be a reasonable option. In terms of potential potency, they're probably a little bit less effective compared to the dopamine blockers, which we'll talk about, but overall they still provide mild to moderate improvement. Most common in terms of side effects are going to be sedation, orthostatic hypotension, bradycardia, again, because the mechanism helps to reduce blood pressure and heart rate with reduction in sympathomimetic flow, and as a result, those are the common side effects that you can see. So what are the 2 that we use? Again, it's just important to be familiar with this. Some of this may be a little bit too much for the scope of your practice, but overall there's clonidine and guanfacine. I tend to use guanfacine more than clonidine. I feel that it has a little bit less potential to cause those side effects, and I can get away with once-a-day dosing because it has a little bit longer half-life. If you're going to use guanfacine, you start 0.05 to 0.1, and I go slow and just do the same interval in terms of increase every couple weeks. Again, tics ebb and flow, they come and go. You don't want to just make knee-jerk dose adjustments within a couple days of when you start. Cap-A is the extended release form. And per the AEN, with their official recommendation, they mentioned that people receiving clonidine are probably more likely than those receiving placebo to have reduced tic severity. And that's just the language that they use in those 2019 guidelines that I mentioned before, in terms of possibly more than likely, probably more than likely. With guanfacine, again, this is the medication that I use. I start 0.5 to 1 milligram at night and increase slowly by the same interval every couple weeks. Maximum dose is about 4 milligrams a day before you get law of diminishing returns. Again, I feel it's less sedating than clonidine. That's just my personal opinion. Intuniv is the extended release formulation. And per the AEN, people receiving guanfacine are possibly more likely than those receiving placebo to have reduced tic severity. So I would say 15 to 20 years ago, a lot of providers were using the dopamine blockers, the antipsychotics or anti-dopaminergics, first line for treatment of tics, and that is not the case, in my opinion, at this point. Now, are there certain situations where sometimes we have to escalate? Yes. They've tried CBIT, or they didn't have access, or we tried the alpha-2 agonists, and they just weren't working. If I do go to the dopamine blockers, I will go to the atypical antipsychotics compared to the typical, but what's the difference? So the typical antipsychotics overall are going to have the most dopamine receptor blockades, so are probably going to be the most effective at reducing tics. But with that said, they come the risk with a lot of side effects, not only sedation, weight gain, but they can cause extrapyramidal side effects due to chronic blockade of these dopamine receptors. So you can get what's called tardive dyskinesia, dystonia, tremor, Parkinsonism. That's why I'll typically go to the atypical antipsychotics, because the way they work is that they have less dopamine blocking potential and more serotonin receptor blocking. Now, in theory, if you're having less dopamine blocking potential, your reduction in tic severity may be less, but the risk of these extrapyramidal side effects like tardive syndromes, dyskinesia, dystonia, and Parkinsonism are a little bit less, but still there. Risperidone and Abilify are the two that I'll use if I ever have to go to that. Weight gain is the most common and bothersome side effect. And you also have to work closely with the primary care providers and pediatricians because it can increase risk of metabolic syndrome. So watching glucose levels, lipid levels, and monitoring blood pressure. So interestingly, there was a study back in 2013 looking at Topamax and the effect in patients with tics. And there was one phase 3 study that looked at this that was statistically significant. And basically they worked the dose up to about 118 milligrams, and that there was improvement in patients with tics based upon those different outcomes of the YGTSS, etc. The problem that I find with Topamax, as well as when I use it for treatment of other neurologic conditions, are the side effect profile. A lot of times it can cause cognitive dulling and slowing, reduced appetite and weight loss. Actually, some people like that, but it can cause paresthesias in the hands and feet, and can sometimes cause kidney stones. If you are going to use it, I start low and go slow, 12.5 to 25 milligrams daily, and increase every couple weeks by the same interval. Per the AEN, they felt that Topamax or Topiramate is possibly more than likely than placebo to reduce tic severity. So overall, when we talk about the medical management, I will go to guanfacine or the alpha-2 agonist first. If I have to escalate, I may do Topamax, especially if the tic severity is not as severe as I think that it warrants antipsychotics. But there are those handful of individuals that sometimes I will use dopamine blockers, but rarely. Now, whenever I do these lectures, I always get the question about medical marijuana. You know, sometimes I can wait to the Q&A, but I know it's going to happen, so I should just put the evidence up here up front. And so this is a hot topic in neurologic conditions, not in just Tourette's syndrome, but in Parkinson's disease, epilepsy, things like that. And we don't have the evidence for the use of medical marijuana in patients with tics. And here are just the two studies that tried to look at that. The first was back in, I believe, 2002, which was a randomized double-blinded crossover study of 12 adults with TS in 2002. So what happened was they got a single dose of THC, the different milligrams, or a placebo. They got one dose, they were rated in their tic severity scales. They had a 4-week washout, and then they took the other dose, again, just one dose, and had the rating scale. And so what they found was that there were no significant differences between the treatments and the different rating scales, including the YGTSS. So then the next year, they tried another study with a little bit better design. Again, randomized, double-blinded, placebo-controlled. Okay, 24 patients instead of 12, that's better. They basically just had the THC group with 1 dose versus placebo, and at least this time they looked over 6 weeks instead of 1 dose, 4-week washout, the second dose, with 6 visits during that time. 7 patients dropped out or had to be excluded, so actually they only had 17 as part of the analysis. And again, they found no significant difference between the THC and placebo group on the YGTSS. So per the AAN, in terms of the recommendations and summaries for medical marijuana, I'll just read them to you. But this is the official recommendation. Cannabis-based medications should be avoided in children and adolescents, not only due to the paucity of evidence, but due to the association between cannabis exposure, adolescence, and potentially harmful cognitive and affective outcomes in adulthood. Compared to placebo, cannabis-based medications are associated with increased risk of short-term adverse events, dizziness, dry mouth, and fatigue. There's limited evidence that THC, dronabinol, is possibly more than likely than placebo to reduce tic severity in adults with TS. So overall, when I have someone come in and they ask about medical marijuana, basically I don't have the evidence to support it. I'm not saying that going forward there can't be different research to look at it, but with our current evidence, I do not recommend it. So what are some of the take-home messages from this at least portion of the presentation, especially for the primary care providers and treatment team? The most important question is, do I treat? Just because someone has tics doesn't mean you have to intervene. You only want to intervene if they're bothersome to the individual. First-line treatment can be initiated by the primary care physician and pediatrician. Sometimes it will come to neurology, but a lot of times if there is co-occurring ADHD, then pediatricians will feel comfortable initiating treatment. If you are going to use medications, then guanfacine, in my opinion, is the most effective in first line. But again, if you have access to CBIT, that is the first line treatment overall. If you have to escalate beyond guanfacine, CBIT, then I would strongly recommend a referral to a pediatric neurologist. And in addition, one of the take-home messages, which is going to be the last section of my presentation, is you have to screen for these common comorbidities, because anxiety, depression, OCD are going to be the symptoms in general, statistically, that tend to linger on into adulthood and are most problematic. So let's get into that. So this is a great graphic representation that the TAA has developed in terms of, a lot of times it's the motor and vocal tics that appear at the surface that we focus on. But deep below that, there's a lot of other comorbidities. Again, whether it's ADHD, anxiety, depression, OCD, rage episodes, and we have to be very diligent, not as physicians only, but as nursing staff and screening questions to really look at these kids and see, are there other things at the surface that we may not see? So the most common comorbidity that you'll probably see is going to be ADHD. Depending upon what reference you look at, it's about 50 to 60% of individuals will have ADHD. A lot of times the ADHD onset will be in similar time frame, around 5 to 7 years old, whereas the mood disorders, anxiety, depression, OCD can sometimes be a little bit later in terms of the teens. You know, there's been a misnomer over the years that using stimulants for treatment of ADHD can either cause onset of tics or worsen tics. And we actually have a meta-analysis from 2015 that showed that did not support an association between new onset or worsening tics and psychostimulant use. Now, are there individual circumstances where the patient comes in and says, you know, I started the Ritalin and my tics got worse? Sure. Based upon our data, though, that overall is not the case. And so if someone has really bad ADHD in addition to tics and we need to use a stimulant to treat, I have no reservation in terms of starting a stimulant to see if we can improve the ADHD. With regards to treatment, obviously you can do cognitive behavioral therapy, which is a non-medication approach. Our data, again, most effective are going to be the stimulants either in the methylphenidates or the amphetamine groups. Non-stimulant approaches are the alpha-2 agonists, as I was saying before, that can sometimes be a 2-for-1 when you're treating both tics and ADHD. And you can also have atomoxetine, which is another non-stimulant approach. Mood disorders, anxiety, and depression are also very common, as I mentioned before. And these are the symptoms that tend to persist into adulthood and are most impairing. I see both children and adults with tic disorders, and I would say that 75% of the time I'm wearing my psychiatric hat in terms of treating anxiety, depression, OCD, compared to 25% of the time with tics. So again, it's very important because the needs of these patients are still there. And we want to make sure that once we transition them into adulthood, we still have providers who are screening and treating the symptoms. Again, you can have non-medication approaches with CBT, which can be very helpful, especially for OCD. In terms of medications, there are different groups of medications, SSRIs, SNRIs, that can be very helpful in terms of treating mood disorders. OCD is another one that we see. Again, depending upon the source that you read, about 27% of patients will have OCD. And at times, it can overlap with complex motor tics, or it can make it very difficult to differentiate. What do I mean? Let's say that someone comes into my office and they tap on my desk 3 times. I said, well, why'd you do that? And they said, well, I just had this urge, this buildup. I just needed to. I felt better afterwards. Okay, that could be a complex motor tic. Then the next person comes in and they knock on my desk again 3 times. I said, well, why'd you do that? And they said, well, I did that to prevent my dog Skippy from dying. That likely is more of a compulsion due to this intrusive thought, for which a compulsion has to be done to lower that. So again, sometimes it can be very difficult to differentiate a complex motor tic from a compulsion. And so I just coined it jokingly kind of a compultic. But it's important to try to get as accurate as you can, because sometimes the treatment approach can be different. When we talk about treatment with medications, SSRIs can also be effective for OCD. In my experience, the dose has to go up a little bit higher for treatment of OCD compared to that for just anxiety and depression. Other comorbidities to consider: behavioral disturbances. We can have conduct disorder, oppositional defiant disorder. Rage episodes can be really difficult for some individuals. And a lot of times that's where the cognitive behavioral therapy, psychotherapy with counselors and staff are really going to be helpful. If this really occurs, from my standpoint, I try to get my child psychiatrist on board too to help co-manage, because it can be difficult for me and there's different treatment approaches. In addition, there are individuals that can have learning disabilities, and so we need to consider IEPs, 504 plans, and really providing any additional resources that we need for our patients. This is a good graphic representation in terms of the age of onset and where the bulk of the symptoms are over time. So as you can see, kind of TS, the tics, and ADHD are a little bit earlier in onset, tend to get better with age, whereas the mood disorder, OCD, tend to potentially start a little bit later and linger on into adulthood. So overall, what is it that I want you to take away from this lecture? Well, Tourette's syndrome is a complex neuropsychiatric condition, and it's not just the tics. There's a lot of things below the surface that can also be present in our patients that we need to screen for. Tics improve with age in the majority. The psychiatric comorbidities, again, ADHD, OCD, anxiety, depression, are the symptoms that tend to linger on into adulthood. You want to treat the most bothersome symptom first. If it's anxiety, treat that first. If it's ADHD, treat that first. If it's a tics, then go ahead. And you want to consider both non-pharmacologic CBT or CBIT for tics and pharmacologic interventions when you're looking at the treatment of both tics and comorbidities. And that's it. Hopefully this wasn't a whirlwind or I didn't go too fast. Here's a list of the different references for the presentation. And at the end, I always like to thank my family. That's my wife, Jess, and my 2 children, Ryan and Emma, because I wouldn't be able to do what I do today without their support. Thank you.
Thank you so much, Dr. Morrison. That was greatly appreciated. I know that we already have some questions. Please feel free, if there's other questions, to put those in the chat or in the Q&A. I see the first question that was in the chat is related to whether or not speech pathologists also treat Tourette syndrome or tic disorders, if that's something you've seen.
So not as commonly. I'm not saying that certainly they could. A lot of times it can get mistaken tics for stuttering. And so it's not to say that certainly if someone is speaking, they have to do like a vocal tic, there'll be a break in the fluency of their speech. But a lot of times people will come in with stuttering that will be perceived as potentially tics. Now, in the end, the treatment approach is going to be potentially the same, as that if there are speech difficulties or disfluency, that's where speech pathologists will be helpful. But they're not necessarily someone that I've referred to a lot for tic disorders. But again, we can always keep that in mind.
Thank you so much. I see another question asking if a copy of these slides can be made available after the event to the attendees.
Yeah, yep, that's fine.
Absolutely, thank you. And I'll leave a moment here to see if there's any other questions.
Was this helpful?
I found it to be very helpful. I appreciated all the details. I see another question here. What is the best way to help a young peer groups understand about tics? Great question.
Yeah, so that's a great question. So I think that that's a multi-directional approach. So obviously educating the patient and family first is very crucial, that tics are involuntary, they're out of their control, they're the same individuals who they are. You know, educating the teachers, you know, the same thing. And for children, you know, it's tough because they can be cruel too, right? In terms of, especially with bullying and teasing. But, you know, what I found is, you know, again, educating others and peers and friends that these are tics, this is the diagnosis. And I think not understanding, you know, kind of at times makes things a little bit worse. And as long as we can continue to educate our peers and friends, I think that is absolutely key. In addition, there are support groups, TA local chapters. In New York State, we had 5, we have 4 now. And so there are different support groups that parents, family members can go to. There are additional resources online that we can use. There are advocates that actually get trained to go into schools to educate peers and teachers about Tourette syndrome. And so those are all the different ways that obviously us as the provider and the TAA and local chapters can be helpful in terms of supporting the individual.
Thank you. I see another question here. Are there any differential diagnoses to consider when onset is later than teens or in the early 20s?
Yeah, so that's a very good question. So during the pandemic, nationally and internationally, there has been a rapid rise in the referral for abrupt, acute onset explosive tics in older individuals aged 13 through 17. And what we're finding is that actually those are functional tics or functional movement disorders. And I don't know if it's a form of potential mass psychogenic illness, but basically, you know, you have to look for atypical features. I'm not saying that onset can't be in 13, 14, 15, but really it's the red flags that we look at: acute onset, abrupt escalation in symptoms, onset of complex motor and vocal tics. You know, they say they're throwing things, they're swearing. There's no simple, you know, tics. We've seen a rapid rise, and this has been presented at the national and international level of the American Academy of Neurology and at other meeting groups across the globe. So functional movement disorder is a potential alternative diagnosis, and that can be very difficult to differentiate because sometimes they may have the premonitory urge. There's no definitive tests to do, but that is one thing that we're seeing over the past 2 years in terms of older onset. They're actually more in females in 13 to 18 years old with abrupt, drastic onset and escalation in symptoms.
Thank you. Another great question. And I do see some comments in the chat that I want to share here. I've seen a lot of bullying with this disorder, so education is key, was a comment from Dr. Urban. See, Dr. Brophy said, this is very helpful information. Her brother had Tourette syndrome, and sadly it wasn't diagnosed until adulthood. That early diagnosis and treatment would have provided a much better quality of life for him. And just another appreciation of the presentation. So thank you so much, Dr. Morrison.
Yeah, you're very welcome. I mean, earlier diagnosis is always the best, right? In any of our movement disorders. You know, that's also the point of doing these, you know, presentations so that we can become more aware. And even if we're able to identify one other patient potentially with this disorder that may have been gone undiagnosed, then I feel that, you know, I've done my job in educating everyone and help supporting.
Thank you again. And I don't know if you want to share the slide so we can get that QR code.
Yep, sure. Give me 1 second.
Yeah, no problem. And I also see that just a great update in terms of the medication. So thank you for addressing and going through those.
No problem. Let me just share my screen, Denise.
Yeah. Angela, I don't know if you want to talk about this evaluation, and then I'll share the link to our evaluation for contact hours. Thank you.
Sure. Thank you so much, everyone. I just want to piggyback on some other things that Dr. Morrison said. The Tourette Association really is a great resource for everyone, for providers and patients. We have tons of free resources on our website, the toolkits that I mentioned in particular. Our YouTube channel is an excellent resource to send parents and youth to. They have We have a lot of pre-recorded webinars on there, some great videos for kids even to watch. And our Youth Ambassador program is really wonderful. Youth Ambassadors, and for our young adults, we have a Rising Leaders program, teaches kids with Tourette syndrome to become advocates for themselves. And that's not even just on Capitol Hill for funding, it's really to teach others about Tourette syndrome for education and awareness and, of course, acceptance. So if you have patients out there and you are not aware of the TAA, please pass them on to us and stay in touch. And if you wouldn't mind taking a few moments to fill out this survey, really gives us a good idea of how this presentation was for you. Feel free to share any feedback that you might have, information that you were hoping to hear. Anything like that is really helpful to us, and it helps us report back to the CDC so we can continue training other providers like yourselves. So that's pretty much it. Thanks again. If you have questions or need additional resources or help finding anything, you can please reach out to myself or even Dr. Morrison.
Thank you. And I do see that we have, I posted the evaluation for contact hours in the chat as well. However, I also see one more question that came in, Dr. Morrison.
Yeah, I can answer that. Yeah, so I think the individual is asking about stereotypies. So, this gets back to phenomenology, and it's really important to understand the difference between what a tic is and stereotypy is. So both are repetitive stereotype movements. Tics are non-rhythmic versus stereotypies are more rhythmic. So when I say rhythmic, think about, a rhythm. So hand flapping, rocking, those are more stereotypies. Stereotypies tend to start earlier, 2 years old, sometimes a little bit earlier, sometimes later. They tend to be the same. They don't ebb and flow and change and morph. They are seen more in excitement and boredom, but again, tics can get worse during, excitement. But they're more rhythmic movements compared to tics that are non-rhythmic. So that is a good way, to try to differentiate from a movement disorder standpoint. Did that answer the question?
I'm not sure if you can type in the chat that it was to whether or not that answered your question, but I think that addressed it, Dr. Morrison.
Okay.
Thank you. And then, so as I mentioned, there is a link to the continuing education platform that can be found in the chat. In order to receive those contact hours, this evaluation must be completed by Thursday, November 11th. You will have access to your certificate once the evaluation has been completed and you've claimed credit. If you do have any questions in regards to your contact hour certificate, please email us at continuingeducation@snhu.edu. And we will certainly leave the room open for a few more minutes here if anyone else has any other questions or is having any difficulty accessing the chat, accessing the certificate. And a big thank you again to Dr. Morrison and Angela for joining us today. Greatly appreciate it. Such wonderful information. And I see a link from Angela as well in the chat for the survey, for their survey.
I guess if there's no other questions, we'll conclude for today.
Thank you so much. I appreciate it. Have a great afternoon, everyone.
All right, take care.
Everyone, bye.